The first issue with composite dentistry. So we are going with problem-based solutions with composite dentistry. What's the major issue we find with composite dentistry is number one issue is color. And the most important question is everything we know is really so. And I'm going to give you a few tips and tricks on how to get good color with our composite resins. So these are the objectives of today's presentation. Learn to accurately assess shade in visually complex teeth. Understand the difference in creating colors from inside out or outside in. Achieve better patient acceptance and become color confident in shade selection for direct and indirect restorations. So form follows function. This is what has been taught to us from day one of dental school. And this is what I'm going to refine more today. So seeing teeth in a whole new light. Seek and you shall find it. I mean, if you really want to learn color, you got to see teeth. You got to see teeth daily, irrespective of what treatment you do. So let's try and understand first the structure. Now this is what is going to make us more color confident. Let's try and see how dentine is. Now if I look at dentine is more opacious, it's more reflective, it's more colorful and thick cervically. But as you come down, it lobes towards the incisor edge. This is how dentine is when we talk about histology. If I look at enamel, it's more translucent. So basically it is the window through which the dentine is seen. It's more opalescent. It is just 0.3 millimeters at the cervical and it increases in thickness incisally as you come down. So if you can understand these structural properties, then it becomes very easy for us to mimic color. So clinically, if I look at this tooth, it's more thin. Enamel is more thin here. Dentine is a lot. That's why you see a lot of color here. So that's why it's highly chromatic. Now as you come down, enamel thickens and dentine tapers. And as you come even more further down, you see a lot of translucency. So with age, chroma increases, hue moves towards more orangish, and enamel thins with age. This is one thing which you should understand. So this is a classical example of two different patients. On your left, you have a 24-year-old young patient with a lot of enamel and a lot of dentine color showing through the enamel. And your right hand side, you have an old patient, a geriatric patient of 69 years old, where hardly you see enamel. That's why you see a lot of dentine. That's why they are patients of high growth. So now when you have to do shade mapping, basically tooth is divided into three zones: gingival, body and incisor. So to be aesthetic in matching shade, one color for the whole tooth is not acceptable. And that is very rampant in many clinics. I have seen many of them communicating shades to technicians. Sometimes they don't even take shades and they tend to forget. And then the next day when the technician calls them, "Doc, what is the shade?" The most common shade to be communicated is A2. So you're making your technician's job much easier. So he's going to paint A2 from incisor to cervical. So when he does that, tooth looks monochromatic. So the whole idea for aesthetics is you have to make the tooth look polychromatic. Give more colors to the tooth. So this is one of the work done by my postgraduate. If you see dentine here, this is exactly what we follow. Follow histology. Keep it thicker here. As you come down, taper it. And then place your enamel. So you get a seamless, beautiful finish. So then now let's try and understand color. Now this is, for the next 15 minutes it will be real fun. And I'm going to simulate what happens in day-to-day clinical practice. Say for example, a patient comes to you now. Say you have to do a direct or an indirect restoration. The first thing you're going to do is map the color of the tooth. Now when you have to map the color of the tooth, the first point what you need to get is the hue from the tooth. Now hue is nothing but primary color of the tooth. So now I need to know what is the hue of my patient. Whether it is A, B, C or D. It's very simple. You have 4 hues in dentistry. Now for you to know what is A, what is B, what is C, what is D, which I am going to tell you. But you need to also know which part of the tooth I look at to get my hue. Now it's very simple. if you see the cervical third of the tooth, the first point of contact when you have to take the hue is the cervical third. Don't look anywhere. Now when you look at cervical third, and if you get something called reddish brown or reddish orange, it is A. If you see yellow or white, it's B. If you see grey, it is C. If you see reddish grey, it is D. So please note this down, that my hue is A. That's the first thing you're going to do. Next point is chroma. As I said, no tooth is monochromatic. Every tooth is polychromatic, more so with canines. Any canine you look at of any patient is highly chromatic than the central and lateral. So now when I start looking from gingival to incisal, I start jotting down my chroma. Now if my shade is A, then probably in the cervical third it's always darker. So it will be A3 or A3.5. And then as I come down, I reduce the saturation of my chroma. So from A3, A3.5 it comes down to A2 and then it comes down to A1. So now I make my tooth look polychromatic. So you really cannot communicate A to your technician. It's very important that you give 3 different chromas. That's the second step. And the third step is value. This will make or break your restoration. Now you have to accurately assess the brightness or darkness of the color of the tooth. Now that is value. Say for example, I am working on a young female patient. Now if you look at most of the teeth, most of the younger patients have brighter teeth. They'll always be in the B1, A1 bracket. But if I am working on an older case or an adult patient, they'll always have an intermediate value or they are towards the darker side. So now from this dark oral cavity, you need to get the brightness or darkness absolutely right. Now these are all things which are very difficult in a clinical situation. That is the reason we get frustrated and at the end we communicate to us A2. That is one thing which should not happen. So now I am going to give you some few tips on color selection. First tip is determine the shades needed for the restoration prior to the preparation. Very few of them do that. We finish the prep, we displace the tissue, we place the retraction cord. Sometimes we even take the impression. If you're doing indirect, we put temporary and then we map shade. Never do that. Do the shade matching prior to your tooth preparation. Even before you give local anesthetic, even before you place the rubber dam. This is the key. Never dry a tooth. Please keep the tooth wet. Be very brief. Ask the patient to wet the tooth and then check the shade. A desiccated tooth will appear lighter than normal. The moment you dry the tooth with a 3-way syringe, the value will increase. And if the value increases, suddenly the restoration will look very off. Select the dentine shade by examining the dentine. So where you look for dentine is always at the cervical third of the tooth. Examine the proximal and incisal areas to select an enamel shade. Always remember, if you really need to have some idea about value of the tooth, look at the proximal and incisal areas, because this is the area which has got a lot of enamel. Never look at the cervical third. So let's try and understand the color language of this tooth. So it's a beautiful picture of a young patient. So the moment I look at this, I can say it's a young patient. Why? Because it's got a lot of colors in cervical third. The middle third is always brighter, and as you come down, there is a translucency, and then you see a halo. So just from tomorrow, try to check all this. The moment you start seeing this, you seem to be more creative and give this back again when it is lost. Apart from that, you see a lot of textures. Can you see the perichymata running here? See the line angle? See the grooves? Beautiful. See, it's got an amber halo here, it's got an inside, it's got a white halo here, that's the translucency. Now apart from the tooth, what's the next most important component? Don't ignore the soft tissue. Soft tissues are going to give you some important clue. Say for example, my patient has got beautiful coral pink tissue. Those patients will never have dark teeth. Just try and observe from tomorrow. But if my patients have pigmented, heavily pigmented gingiva, probably they have darker teeth. So these are going to give me clue on terms of value, whether it's bright or dark. So soft tissue has to be a part of color mapping procedure. So these are the rules of color and value. This is the basic recipe for all of you. From tomorrow, any restoration you do a veneer, you do a class 4, you do a class 3, you do a class 5, you do diastema closure, you do a ceramic crown, you do ceramic laminate. This is the basic recipe. Divide your recipe into gingival 1/3, middle 1/3, incisal 1/3. If it's a young patient, then I know gingival 1/3 has a lot of colors. It will be highly chromatic there, but the value will be low. For young patient, the middle third I'll always keep bright. Say for example, if cervical third is A3, I will keep it A1 in the middle. And then as I come down, if there is translucency, then automatically value will lower. Because translucency is nothing but glass-like, so a lot of light will pass through. Right? So in any structure where light passes through a lot, value will be less. But in old patients, we will not see a lot of translucency, so that probably value will be mid-value or high value. So this is how you communicate to your technician as well. If you are giving your work to some good labs, they have all these zones marked, so you need to tell them the colors. Right? It's not about communicating over the phone and telling them just give me A2. No, that's not aesthetic dentistry. So what are we trying to do is getting all these things right to give aesthetics. For me, the most important component is value, then comes translucency, then comes form, surface texture, chroma, and then hue. And I'm sure all of us use Betapan Classic, which is more for ceramic, not for composite. It starts with A1, ends with D4. It's a hue-based shade. Please remember, Betapan Classic is based on hue. And if you want to know the value, you need to buy a Betapan value-based shade guide. And the value-based shade guide starts with B1. Because B1 is the brightest. That's why patients ask for whitening. Why do they ask for whitening? Because they want to brighten their teeth. They want to change the value of the teeth, not the color of the teeth. Right? That's why everybody wants B1, because B1 is the brightest. So now let's look at shade tabs. There are many clinicians who use shade tabs, but I don't believe in shade tabs, but I want to show if you use shade tabs, there are a few things which you should consider. So basically all the shade tabs will have high chroma, high opacity, and as you come down the chroma increases. So just kindly look at that, and then you should know how to place the shade tabs. Now this is the shade tab based on value. Starts with B1, then A1, then B2, D2. These are high value. These are intermediate value. These are low value. So I will use these shades for old patients, adult patients, young patients. If you are not able to buy a Betapan value-based shade guide, kindly take this picture, download it from Google Images, so you know what are the value shades, how is the sequence. So let's dissect a central incisor. When I dissect a central incisor, for me the first most important point is the contact point. Say for example, whatever I'm doing a diastema or a veneer or a class 4. The mesial contact, all this we have learned in first and second year of dentistry. The mesial is always less rounded, it's straight, lower, contact is always lower, that's why embrasure is more shallow. The problem arises when the contact goes slightly up or contact comes more low, then you don't have the embrasure. And remember, if you don't have embrasures, then the restoration will not look good, because these are beauty spots. You have to take care of your embrasures. If you look at distal, it's more rounded, bulbous, distal contact is more higher, that's why embrasure is more deeper. So if you look at a smile line, embrasures are very, very wide along with the smile line. So in the center they are small b. As you go distally, they open up more between central and lateral, lateral and canine. And then comes your gingival zenith. Zenith is nothing but the highest point of contour where the gingiva curves. So if I draw a straight line in the center of the tooth, the zenith will always be distal, the highest point where it curves. If you don't have that, please get that. You can use blade, you can use cautery, you can use laser, you can use anything to get that. I mean this, the highest point of contour. Then let's look at angles. A central incisor will have 3 angles, and the most important angle is number 3. It's an exaggerated angle which you have to open it out to give the impression. So when I do a diastema, I always take care of these 3 angles. So I place my composite in this way. You know what is the most common mistake when they do diastema closure? They don't think about these angles. They place the composite straight. So then that composite always hits this papilla. And that papilla is always inflamed and red. Right? So this is a key point. Then comes your developmental depression. Apart from that, always, whatever kind of aesthetic dentistry you do, whether composite or ceramic or CAD/CAM or anything, move around the patient to look at the restoration. And the most important view is incisal view. Come in front of the patient, your eye should be at the level of the incisal edge when the patient is reclined in a reclined position, and look at the incisal view. Because this is going to tell you where is my cervical bulge. I mean the contour of the restoration. Always come onto the proximal and go behind the patient and check for contour. So always do this, otherwise we make our restorations very flat. Then comes your developmental depression. I am going to show you today how to give developmental depression in the hands-on. It's very simple. The easiest instrument to use is enhanced cup after you finish your gross finishing. Then translucency. Now this, of course, you need to give with effect shades. You really cannot depend on your basic shades. And most of the manufacturers will not give you all this. You have to buy them as refills. The basic kit will have all common shades. They will not have effect shades. So you should know what shades you need, and accordingly you can procure them. Then tints. We also have tints available in the market. You have colors. You have brown, light brown, medium brown, white, blue, grey, white. You have everything. So keep those tints. Sometimes you never know. You have to mimic some spots. You need those. So these are all the morphological considerations. If you look at them, if you get them right, then you get a very good restoration, lifelike restoration. So for me, the first most important point is incisal edge position. Then my line angles are very, very important. Mesial and distal transition line angles. And that is very important in a diastema group. Because what happens in a diastema is, if you have a 2 mm diastema or a 1 mm diastema, you know the tooth is going to widen when I restore. So now, to an eye, it looks wider, it looks fat. So it's only with your line angles, when you play with your line angles, you make the tooth look narrower. So you can push your line angles towards the center and your tooth will look narrower because you're seeing from line angle to line angle. This is called illusion. So line angles can give you good anatomical effect. Then comes your incisal abrasion, your cervical bulge. Every restoration should have a cervical bulge. And only when you have cervical bulge, you have the line angles. Developmental grooves, textures, marginal ridge, mammalions, and incisal cable. Right? So if you have a young female patient aged between 12 and 20 years, they always have a type 1 incisal translucency patterns, as I mentioned, and they always penetrate into the dentine like this. So that's why when you're working on a young female patient, always make sure your dentine layer is erratic like this. The most common mistake when we layer composite is we are too flat. Right? Never do that. The dentine shade has to be irregular and erratic. Make our job much easier. But the problem is, we have so many challenges daily. Day-to-day practice. The first big challenge is, what technique should I use to do my restoration? Should I use a total edge? Should I use a self edge? Or should I just use selective edge? Now these are three different protocols. Total edge is very, very popular, highly technique sensitive. Self edge is very promising, it's not technique sensitive. But there are some issues with self edge as well. And then came the new technique that's called selective edge, where you selectively etch only the enamel, wash it off, rinse it, air blow, and then apply self edge. So I'm going to use two different systems on a single tooth. So that way I'm going to get good marginal integrity on my enamel. Then comes, how is my substrate, to what I am wanting to, whether I am wanting to whiten dentine, sclerotic dentine, reparative dentine, dry, moist or wet dentine. Because there are situations where you do indirect pulp capping and you know there is a change in structure of dentine. There are sometimes you are working on a hypermineralized dentine, on a deep dentine. So situations are always different. But the most important point is, how much of enamel is remaining surrounding my preparation. That's the key. If you can see that, then be assured the bonding will not fail. The moment you see that enamel is reducing and at one stage you don't have any enamel, then it's a big issue. Then it depends on your preparations, whether it is retentive or non-retentive. If my preparation is retentive, then I am better off with self-edge. But if my preparation is non-retentive, then I have to use total edge, no doubt about it. Then it depends what are you doing. You are doing just a restoration, a veneer or a crown, inlay, onlay or an implant restoration. Because for every damn procedure, the bonding protocol is not same. That is what you need to understand. I'll give you a simple example. I get so many queries on laminate cementation. You know, there's always this confusion with laminate cementations. That's why very few people put their hand in laminates. Because the most difficult and stressful part of a ceramic laminate is to cement that. And believe me, it's not easy. It's not easy. So now when I'm bonding a ceramic laminate is a light cured restoration because it is less than 2 millimeters, so light will pass through. So now when I'm using a resin cement to lute a ceramic laminate, please remember you have to use only the base paste of your resin cement. And please don't mix the base and catalyst of a resin cement. Now most of the cements available, like for example you have Calibra from Dentsply. Now that is available as two paste system where you have base, catalyst and you have two bonds. One light cure bond and one self cure active. Now in India, why they don't promote veneer cement as such, only made for veneers, is because they are not much takers. But you can use these cements. But the only catch is, I am not going to mix base and catalyst because the moment I mix base and catalyst, this cement is going to turn dual cure. If it turns dual cure, tertiary amine from the catalyst will discolor my laminate over a long period of time. But you can mix both if you have to cement a crown, if you have to lute a post and core. Because they are all dual cure because light will not pass through that distance. And for a laminate cementation, I have to use only a light cure bond. But for crown cementation, I have to use a dual cure bond. So if you have to make a bond dual cure, you have to mix 1 drop of light cure bond, 1 drop of self cure active. So these are all the confusions which go on in a clinical practice. So let us try and understand the proper total edge technique. Now I know these are things which you should learn from experience, which you should know yourself, because all these things cannot be taught. But there's something which can be improved upon is your imagination. Because you really cannot see what you're doing. Say for example, you have prepped your tooth now, and you know when you have prepped with diamond or a carbide, you create a smear layer on the surface of the dentine. Now when you're using a total edge technique, that means you are using phosphoric acid. You can use phosphoric acid between 30 and 40%, anything is okay. But you know, how do I select an etchant? That's also a very important, critical aspect of selecting an etchant. You have hundreds of manufacturers selling etchant. But you should know which etchant is best for me. And how do you know that? It's the viscosity. I mean, you should control it. The etchant should not control it. And you'll find many etchants in the market where you push and it just flows everywhere. That way you really cannot practice adhesive dentistry. Be focused. These are key things what you're doing because this is going to keep your restorations for long. So I start from enamel, go on to dentine, immediately rinse it off, gently air blow, then I'm going to apply my adhesive. So in between these time, when I do that, what's happening is the etchant is going to remove the smear layer completely, which you can't see. Along with that, it also exposes a little bit of enamel and dentine because it demineralizes enamel and dentine. To what level, it is variable. It can be 3 microns, 4 microns, 5 microns or 6 microns. So now when it has removed enamel and dentine, what is exposed is the collagen. Again you can't see. So imagine all this. At this point of time, keep the surface a little moist. Don't be aggressive. Take a 3-way syringe from the side of the tooth and gently air blow. After that, apply 2 coats of adhesive. Now all the adhesives should be refrigerated at 2 to 8 degrees centigrade. This is also very, very important because a manufacturer will give you 1.5 years of expiry, but he is not guaranteeing you on the chemistry. That is in your hand. You have to make sure that the chemistry is intact. So please make sure that you have refrigerated, you have removed it half an hour prior to your case. So the refrigerated adhesive comes back to room temperature. Because you cannot cure an adhesive at 2 to 8 degrees centigrade. It should come back to 25 degrees centigrade. Please shake it well before use because please remember an adhesive has got 2 different chemistries. One is resin, one is solvent. Resin on its own cannot travel inside. It needs a solvent, that is a vehicle to push. And what remains on the surface when you are air blowing is solvent, not the resin. And you cannot allow the solvent to stay there. Because if you allow the solvent to stay there, the composite is not going to cure. So these are 2 things because there is always some phase separation. Say for example, if you have not used your adhesive for 2 or 3 days, please shake it. Otherwise the resin goes down, the solvent is on top. And also know your system well. Know which kind of adhesive, what kind of solvent you are using. Whether it is an acetone based, butanol based, water or ethanol based. Everything has got some significance. These are some small things which makes a huge difference. Now say for example I use an acetone base which is the classical most popular prime and bond NT. Now acetone has got high vapor pressure, so it evaporates very fast. So it gives you very little time to work with. So you have to be literally very quick, just 20 seconds and you're off. If you're using a butanol based, that's the most forgiving, that's XP bond, then it's giving you a lot of time to work with. So now what happened is initially when I was using prime and bond NT, I was a big fan of prime and bond NT. So we got some beautiful results. So we followed the instructions of prime and bond NT. But then we switched over to XP bond. This can happen to anybody. You switch over to adhesives in no time. So when you switch to any kind of bond, know the instructions because chemistry is different. Now I started using XP bond as prime and bond. That was called overconfidence. So if you read the instructions very carefully with XP bond, since it is butanol based, butanol is very slow to evaporate. That means you have to leave the adhesive on the surface of the tooth after application for the next 20 to 30 seconds. So this way, most of the adhesives are varying in terms of instruction. So that is very, very important. And please be very judicious with your adhesive. Don't ever think that they are very expensive, and don't try always to take whatever is remaining on top of the bottle. After you remove the cap, I see many of them take from here. When you do that, you are just taking the resin, there is no solvent. So please judiciously dispense 2 drops and then apply it judiciously. I mean literally I should see a lot of adhesive. And then I air blow and I light cure. I achieve good hybridization. And then I place my composite. Say for example, you etch, you wash off the etchant and you vigorously air blow now. You don't keep it moist. It happens sometimes. You know what will happen? All the collagen will collapse. You don't see this again. So you feel you have done good bonding, you proceed with your adhesive application. And you know where all the adhesive goes? It goes into this collapsed network. This may stay for about, say, a month, 2 months maximum. And then you see your patients coming back to you with complete debonding of restorations. So that's why it's very important to keep the surface a little moist. The only problem is we really cannot judge how wet is wet and how moist is moist. That's the only problem. But I'll give you one tip. The moment you bond, you cure, if you see a glossy surface just before applying your first composite layer, that means you've bonded it really well. But if you don't see that shiny glossy surface after bonding protocol, please repeat your steps. Right? Now let's look at self-etch. So the self-etch protocol has totally eliminated phosphoric acid. No phosphoric acid at all because these are weak phosphate ester monomers. These are weak acids. That is why I call something called as dwelling time. Any self-etch you use from the market, the application time would be 20 seconds. 10 seconds one coat, another 10 seconds second coat. But what they say is, if you want reasonable demineralization and hybridization, you have to allow the self-etch to stay on the surface for the next 20 to 30 seconds because these are weak acids. Again, it depends on what kind of self-etch you are using. With a self-etch, you get some mild self-etch, you get some acidic self-etch, you get some neutral self-etch. So whenever you use a self-etch, please know the pH of your self-etch. That will decide whether you need to leave it for long or you need to do it quickly. Because if you are using Xeno 5 from Dentsply, then you don't have to wait for so long because it's slightly acidic. The pH is about, say, less than 1. So it demineralizes as good as your total etch. So basically self-etch is bonding through the smear layer, it is eliminating some smear layer here, some smear layer here, it is modifying it, and it is keeping the biological band-aid intact. That's why patients don't go into post-operative sensitivity. So then it bonds through a smear layer, you air blow vigorously, you light cure, you place your composite, you get good hybridization. But then again there is some confusion. when to use self-etch. So these are my points, my experience. If you are using total etch correctly but you still have some problems, you can switch to self-etch. If your sensitivity seems to be focused primarily on posterior, that's the usual thing what happens. Most of the posterior composites fail because of sensitivity, and use self-etch. If honestly you don't see yourself routinely using a rubber dam, now this is very critical. If I am doing any posterior restoration, then rubber dam is very, very critical. And if you are using total etch, it even becomes more mandatory. So otherwise it's very difficult. If you are using few indirect all ceramic lab process restorations, don't use self-etch. But this is the catch. If the majority of the preparation is in dentine, use self-etch because it does not work as good as on enamel, especially uncut enamel. So for diastema closures, for direct veneer, self-etch is not advisable. Then comes the preparation technique. So basically, if you have to do aesthetic restorations, please remember you need two bevels on the labial side. If you are doing an angle build-up. Now the most common issue with angle build-up is complaint of patients coming back telling you that I can see that demarcation, I can see that line. Now you know why that line is? Because you have missed on one bevel. It's a simple trick. So when you do a class 4 build-up, you give two bevels on the labial, one on the lingual. Now the first bevel is a long bevel. That's a bevel on enamel and dentine which is 2 millimeters wide. But the depth is only 0.5 millimeters. But when you give that long bevel, you get a straight line. Am I right? You get an absolutely straight line, and that is what is seen once you finish. Say for example, I am doing an angle build-up of this. So I have given a long bevel. Can you see that? It's a long bevel, 2 millimeters wide. Width is very important. Don't be too conservative here. If your width is less, then you will not get good merge. 2 millimeters, 0.5 depth. Now I can see this line. I need to break this line. Because I can perceive whatever is straight, but I cannot perceive whatever is up and down. And that is a simple thing what you have to do in your practice. So always take a needle burr, always use a diamond, and then give a scalloped bevel over the long bevel. So you break that straight line into a curved line. That's the simple logic. Now when you do that, now nobody can tell where is the line. And please believe me, it works. Apart from this, when you etch, I have seen many people etching only till the bevel. One more trick, over etch till here. So when you etch till here, you remove even normal tooth structure about 30 microns. Now you get beautiful blend. So these are the tips I can give you for a class 4. Two bevels. Lingual bevel is you cannot, because nowadays most of the adhesives give good bond strength. But if you really want to give a lingual bevel, you can give, but I don't. I only give two bevels here, over etch, and always finish your bevels. Don't keep your bevels rough. Always use a disc and finish the bevels. Also the edges. See now I cannot perceive the straight line. You see the curved line now? That's very important. I over etch it slightly. Now I get beautiful blend. Let's look at a class 3. Same preparation technique. Long bevel, scalloped bevel, over etch. You know this is the most difficult class 3 to do. You know why? It's through and through. You don't have the facial window, you don't have the lingual window. The easiest class 3 would be lingual approach, where you have the enamel, facial enamel intact. Whatever shade you put, it's hardly going to matter. The second most difficult is where you lose the facial enamel. And the third one is through and through. In this I can give you a tip. After you give your bevels, you etch, always put one layer of opaquer first. Block the light and then put your dentine enamel. If you don't block this light which is passing through, then it will always look as a black shadow. You must have seen that. Very, very common. Then let's look at a class 5. For class 5 preparation technique, you have to give bevels, no doubt about it. But you can't give bevels here. So don't do anything here. Use your retraction cord. It's a must for class 5. Remove all the decay if there is anything. Just roughen it with a diamond, football, and then give bevel coronal. So I give a long bevel here and a scallop bevel. Same thing. But I give it coronally so it blends well. Let's look at a class 3 case. Now this case came to us. He's a male patient. And he tells me this was done about a couple of years back. It didn't look that bad at that point of time, but now it looks awful. Now the moment you look at this case is a classic case of non-preparation composite restoration. Preparation has not been done at all. They've just etched, bonded and placed the composite. So see, this demarcation is become even more exaggerated as days pass by. For such case, what do you have to do? First do the shade matching. If you're using a tab, place it the same way as I told you. Take a small round burr, remove the old restoration. The moment you remove the old restoration, see there is no preparation whatsoever. Now try and analyze at this point of time. See, this is what is very important. Doing composite restoration is not a big deal, but planning is very important. The moment I look at this restoration, I know I am going to work with a lot of enamel area, very less of dentine area, because it's all proximal and inside. And second thing I need to correct is to give a lot of bevels here, to get a good blend. So I take a needle burr, keep the burr at 45 degrees, give a long bevel, break the long bevel line, give a scallop bevel, finish the bevel, etch and bond, light cure. I use my spectrum bond in this, then I use my shades. Now what do I do in this? Say for example in this particular tooth, you know you have to put a lot of enamel but very less of dentine. Then I'll give you an idea. Always start from outside inside. There are two kinds of layering technique. You can start from outside then go inside, or you can do inside outside. Start inside, go out. Now in small cases like this where it is not extensive, it's always a better idea to establish the enamel first and then go inside. Right, so that's exactly what we do. We first put enamel, get the contact right high up there, so you have this embrasure, and then put a little bit of dentine here and mask it. And then start finishing and polishing. This is a very simple case. Follow all the protocol and you get seamless finish. Absolutely seamless. You can't see the line. Now let's look at class 5 situations. I'm showing you all basic cases to start with. Patient is not happy with this. Patient has got some sensitivity issues, some leakage here, more glass ionoma. So we remove all the restoration. We give bevels. Retraction is very important. Always use self-etch. I use a lot of Xeno 5 here. And then always use a small little bit of flowable in the center. Don't make a mistake of placing the flowable completely all over. Because please remember, class 5s are very, very tricky and dicey in terms of post-op sensitivity. They've got high C factor. So if you have to place a flowable liner, place it exactly in the center. You know why? So that there are a lot of areas where the shrinkage force can dissipate. If you cover everything, then it will shrink in the center. Then you have leakage again. So then you can apply your increments in wedge shape, never connect two walls. That's the rule number 1 of composite. Whenever you do a posterior or a class 5, if you have the buccal and lingual wall, never connect two walls. The moment you connect, the cusps are going to be in a straight position, patient has post-op sensitivity. So build wall by wall. If you are doing a posterior composite, build cusp by cusp. So keep some free space around the increment. That's the trick. And if you are trying to build this up with completely flowable, then I do it in increments. First in the center, then on this side, then on this side, then on this side. So I'm trying to manage the C factor. Then I do finishing and polishing, and I get good result. Class 5s are not usually in the aesthetic zone, so you just have to use one dentine shade, don't break your head. Some class 5s like this on maxillary canines, you get good result. Especially if patient has got high smile line, then I will use a sculptable composite, otherwise I just use flow. Now let's look at 3-layer trendy. Let's come to angle build-ups. Okay, so from here we got it here, but let's see how we got it there. So basically you have situations like this, young kids coming with trauma, angle build-ups, angle fractures. So you have two situations. One patient comes to you like this, where you don't have the lingual plane. You know what is frustrating in a class 4? to build the lingual plane. That takes a lot of time, and then you get frustrated when you come onto the label. So make your job much easier by using a putty index technique to get the lingual plane in 20 seconds. So say for example a patient comes to us like this, we always look at the incisal view to look at the contour of the restoration, and then we do immediate mock-up. Just take some old composite, take it in your fingers, place it on the fractured tooth, make sure you have adjusted the occlusion, because I don't want any high point, I don't want any finishing and any major finishing on my lingual or my palatal of my central incisors. Then I check with my patient, don't bother about labial, just make sure your lingual is, palatal is perfect. Now patient is fine, patient says I'm okay, then I immediately mix putty, make an index of your lingual which you have just built now. You get your index ready here, so now you have your impression, you give your bevel, long bevel, scallop bevel, over edge, place the index in the patient's mouth, so because you want this in 20 seconds. That's the whole objective. Say for example, patient has come with an old class 4, but he has the lingual plane intact. Then you have the advantage of taking the template immediately in the patient's mouth. Say for example, it is an extensive class 4. You are not very sure of your mock-up. Then the only problem is you need to take an alginate impression, send it to your technician, he does the wax up. But the problem is patient has to come twice. So of that cast you make a lingual stent. So now we over edge, we bond, we slightly lubricate the index so that the composite doesn't stick. And in this case we used a clear enamel. Now this has been my favorite composite since years. I've done a lot of cases with aesthetics HD, especially the enamel shades. You get beautiful enamel shades, you get clear enamel, yellow enamel, amber enamel, grey enamel, you can get any enamel shades. So the first shade on the index would be a clear enamel. But please remember it should be 0.5 millimeters in thickness only. So place it until where you want, put this in the patient's mouth. You have still time to adjust, make sure you have adapted it well, make sure this is less than 0.5 millimeters, hold the index firmly and cure it from the labial. Now the moment you cure it from the labial, you get this seat, beautiful seat on which you are going to layer now. And believe me, to get this in an anatomical way is very frustrating. Freehand is very, very difficult. Try and adopt this, this really works very well. Now once we get there, we additionally cure it, because remember we have cured only from labial, now we cure from lingual. Now after that, I always take an opaque composite. So if you want to hide that demarcation beautifully, please use a thin layer of opaque composite at the junction of tooth and the fracture. So what this opaque composite will do is, it will block light here. Now why that demarcation is seen? Because it's all about dynamics of light. So use opaque, very thin layer, so it's going to block your light. And then cure it. Now I start with layering with my dentine, place my dentine. Now when you are placing dentine in a class 4, make sure you taper it more lingually. Means the dentine thickness should be more here, as you come down, taper it. I see many of them just put one layer and they keep the thickness exact from top to bottom. That is when all the problems start. Always keep the dentine shade irregular, never make it flat, keep it irregular. And now judge how much space you have to place your enamel. Always come to the side of the patient, go behind the patient, come in front of the patient. This is going to give you some clue. And then I place my enamel. Before placing my enamel, I know this patient has white halo at the edge. So then I use my white shade from Aesthetics HD. You get it absolutely white, it's so white. See here? It's very, very white. So just place this in the form of a ribbon at the edge. See, I'm working in a very small increments. See, if you have to do a good job with composite, work with very small increments, work area-wise, work zone-wise. Don't just put one layer completely and then do finishing and polishing, it doesn't work. So I'm going to put my white shade here to get that halo effect and then top it up with my enamel. Then I take my grey enamel, top it up with my grey enamel. Contour your restoration, then start finishing and polishing. Finishing and polishing is the most ignored aspect when it comes to composite dentistry. I see many people just use one carbide burr and send the patient. Then what do you expect? Then we blame the material, that this composite doesn't work in these colors. It's a simple rule of thumb. If you take 20 minutes for a build-up, you take 20 minutes for finishing and polishing. You need to follow the protocol. The first protocol is BP blade. BP blade number 12. That's your best finisher. The cost-effective instrument should be BP blade number 12. I remove all the excess from my BP blade number 12 and then use my carbide. To start with, you should use a 12-fluted carbide, then jump to 30-fluted carbide. Because any finishing and polishing protocol should come with a sequence. Start from coarse, then go to fine. So of the same burr, I am going to use a 12-flute and a 30-flute. Palatal, I am going to use a football. Cervical, I am going to use a short needle. So I need 3 different burrs with 2 different grits. So basically I need 6 burrs of same shapes but different grits. And always do dry because you want to see what you have done. No water coming in from the aorta port. Off it, do it dry. And then I use my needle burr to give some characteristics, to give some textures. But if you are using this, be very careful, always use in a micromotor. Don't use aorta because you lose control. And then I use my beautiful enhanced cup to give some characteristics like developmental depressions, which I am going to show in the hands-on. And then I use the disc on the edge, on the embrasure area, on the proximals. Then from here, you get it here. See, these are highly textured things. Now if you look at this restoration, I am not happy. In the oral cavity, it looks absolutely beautiful, seamless. Patient cannot identify. But see the effect of photography. If you look at it very closely, if you see my translucent shade is a very little more. That is what my digital photography is telling. But otherwise, my shades are pretty okay. But my translucency is slightly more on either side. So this is how you learn from photography. That's why photography is so very important. Please document your case. You just need to buy a simple digital SLR with a macro lens. Don't think about ring flash and contrasters at this moment. But if you want to start off, these are 2 things obviously.